Hello everyone, I am Dr. Jyoti Verma. In this class, we will be discussing physiological changes in pregnancy and anesthesia concerns related to these physiological changes. Our class will be divided into two parts. First, we will discuss physiological changes in pregnancy system-wise, CNS, RESP, CVS, and so on. And then after that, we will discuss anesthesia concerns related to each system and overall. So let's proceed. First system is central nervous system. So how central nervous system is affected in pregnancy? If we talk about inhalational agent, the MAC of inhalational agent decreases by 40%. And it becomes normal at third day of delivery. If we talk about uptake of inhalational agent, it gets faster in pregnancy due to increased minute ventilation, which will come again in respiratory system. So if we talk about inhalational agent, the MAC decreases by 40%, which becomes normal at third day of delivery. If we talk about local anesthetic, the minimum local anesthetic requirement also decreases by 30% for epidural. This is because there is increased sensitivity for local anesthetic. Why there is increased sensitivity for local anesthetic? It can be due to two reasons. It can be due to hormones. It can be due to changes in epidural venous plexus. So what are the hormonal changes? Hormonal changes are changes due to progesterone, which increases sensitivity and has a sedative effect. And there are changes due to beta endorphins as well. If we talk about changes in epidural venous plexus, so what happens in pregnancy? Obviously, there will be distension of uterus because of the baby, and it may lead to obstruction of the inferior vena cava. Obstruction of the inferior vena cava will distend epidural venous plexus and increase the epidural blood volume. So, due to distension of the uterus, there will be increased epidural blood volume. So increase in epidural blood volume can have many effects. So let's discuss those. So increase in epidural blood volume will have four effects. What are the four effects? One is there are chances of intravascular injection of the drug while injecting drug. There is chances of decreased spinal CSF amount. Due to increased blood volume, the CSF volume may decrease. Third is decreased epidural space volume. The space volume also decreases. As we know that epidural space is a potential space, still that little space volume also decreases. Then the fourth point that changes because of an increase in epidural blood volume is the pressure within the epidural space increases. So changes due to distension of the uterus leads to increased epidural blood volume, which further leads to increased chances of intravascular injection of the drug. There are chances that the CSF amount decreases and there is space reduction in epidural space and there is pressure increase in epidural space. Due to decreased spinal CSF and due to decreased space volume, the cephaloid spread of the drug increases. The chances of cephaloid spread of the drug increases. Due to increased space pressure, identification of epidural space becomes difficult. So these are the changes which happen in pregnancy due to distension of the uterus, leading to increased blood volume and further leading to these changes and finally leading to increased chances of intravascular injection of the drug. Cephaloid spread of the drug, and difficult identification of the epidural space. Now, after these changes, if we place the epidural in a patient and we have to check the position of the epidural space. So, for that we give test dose. For test dose, we use 2% lignocaine with adrenaline. So, in adults, we use 3 ml of of 3 ml of 2% lignocaine with 5 micrograms per ml of adrenaline. So, this is the standard dose we give in our institute in adults. So, the uh, the aim of giving lignocaine is to rule out intrathecal placement of epidural catheter, because if the epidural catheter is in the subarachnoid space, there can be blockade, motor blockade or sensory blockade, okay, of the patient. Then the purpose of giving adrenaline is to rule out intravascular placement of the epidural catheter, because if the catheter is placed intravascularly, there will be increase in heart rate followed by increase in BP. And intrathecal placement along with motor or sensory weakness will also show perioral numbness as a sign of intrathecal placement of the catheter. So, test dose in epidural will have decreased reliability due to multiple confounding factors in pregnant patient. So, mainly lignocaine has less of an impact in pregnant females, but use of adrenaline is difficult and has many confounding factors. Adrenaline decreases the uterine blood flow due to vasoconstriction. So it can compromise the fetal circulation, placental circulation. Alternatively, we can use isoproterenol, we can use fentanyl, we can use a more dilution of adrenaline to prevent vasoconstriction and decreased uterine blood flow. And we have to avoid giving test dose during contractions. So many institutes, what happens is they avoid test dose altogether, and we give the epidural dose like in aliquots like a test dose only, meaning we give very little amount of drugs so that if it gets misplaced, we are not in danger and there is no toxicity of local anesthetic. This was about central nervous system. Inhalational agent MAC decreases, local anesthetic MAC, minimum local anesthetic requirement, decreases. There is increased chances of intravascular placement of the epidural catheter. There is increased chances of capillary spread of the drug. There are increased chances of difficult identification of epidural space, and test dose is less reliable in pregnant females, and we can use isoproterenol, fentanyl as an alternative or give in more dilution. Talking about respiratory system. So the various parameters are changed. Some parameters increase, some decrease. So we'll discuss each of them and then their significance in anesthesia and pregnancy. So minute ventilation increases by 45 to 50%. Respiratory rate also increases by 0% to 15%. Tidal volume also increases by 40 to 45%. So, minute ventilation, as we all know, is a product of respiratory rate and tidal volume. Both these increase and minute ventilation also increases. Talking about inspiratory reserve volume increases by 5% approximately. Inspiratory capacity increases by 5 to 15% approximately. If we talk about oxygen consumption, there is an increase definitely at term. It increases by 20 to 35% as the labor progresses. In first stage, it is 40% increase, and in second stage, it is 75% increase. Talking about the parameters which decrease in respiratory system, in pregnancy, expiratory reserve volume decreases by 20 to 25%, residual volume decreases by 15 to 20%, functional residual capacity decreases by 20%, and total lung capacity decreases by 0.0 to 5% decrease. There is no change in vital capacity, FEV1, FEV1 by FVC ratio, and closing capacity. These values are taken from the standard book Miller's. Then talking about other parameters, as the patient's respiratory rate increases, tidal volume increases, minute ventilation increases, the CO2 washout increases. So the value of PaCO2 decreases from 40 mm of Hg to 30 mm of Hg approximately. pH becomes mildly alkalotic, that is 7.42 to 7.44. PO2 mildly increases and the ODC shifts to right. The fetal ODC is on the left of the maternal ODC. If we talk about P50, it increases from 27 mm of Hg to 30 mm of Hg. Pattern of breathing in a pregnant female is thoracic. Why? Because there is distension of uterus. Distension of uterus leads to elevation of the diaphragm and it increases the AP diameter of the chest. This happens also because of relaxation of ligamentous attachments due to increased relaxin hormone. So, increase in AP diameter of the chest leads to thoracic breathing. Then the pulmonary blood volume increases, but there is no change in pulmonary pressures because of vasodilatation of the pulmonary vessels. So, volume increases, but the space also increases, so there is no change in pressure. Clinically significant things for us or star points to remember is that we already studied that FRC decreases in pregnancy. We also studied that oxygen consumption increases in pregnancy. So combining these two effects will lead to early desaturation of the patient. So what we have to keep in mind? We have to keep in mind that we have to pre-oxygenate the patient very well if we are planning general anesthesia. And we have to give oxygen supplement if needed in regional anesthesia. So decreased FRC and increased oxygen consumption leads to early desaturation of the patient. Another star point to remember is decreased FRC and increased minute ventilation leads to increased or early uptake of inhalational agent. That meaning that we will achieve MAC early in a pregnant female as compared to a non-pregnant female. Other respiratory changes are in airway. If we talk about airway, there is capillary engorgement of the airway, also associated with mucosal edema. All these things, capillary engorgement and mucosal edema, leads to more chances of trauma, more chances of bleeding due to increased vascularity, more chances of obstruction of the airway due to edema, and the MMPG grade increases. Combining these factors with other difficult factors such as patient's breast become heavy due to hormonal changes, patient's tongue become large, and there is risk of aspiration. All these factors make the patient prone for difficult mask ventilation and difficult intubation. So the anesthesia concern is we have to consider each pregnant female as difficult mask ventilation and difficult intubation. Anticipated. So, always a senior or experienced anesthetist must be present. We should prefer gentle, swift laryngoscopy or instrumentation, with preferring smaller size endotracheal tube for intubation because of airway edema. So, discussing the respiratory system with the anesthesia concerns, we have to just keep in mind that increase in minute ventilation leads to increased uptake of inhalational agent. Early uptake of inhalational agent leads to thoracic breathing. Increased oxygen consumption leads to early desaturation. Decreased functional residual capacity leads to early desaturation. Upper airway changes make the patient more prone to trauma, bleeding, obstruction, and makes her a candidate of difficult mask ventilation and difficult intubation. After finishing respiratory system, we will talk about cardiovascular system. The changes in cardiovascular system are, uh, we will discuss each parameter and the specifically then anesthesia concerns. So, intravascular fluid volume increases 35 to 45%. Plasma volume increases by 45 to 55%. RBC or erythrocyte volume increases by 20 to 30%. As there is less increase in erythrocyte volume as compared to plasma volume, there is hemodilution, which we will discuss in next few minutes. Hemodilution, this is known as physiological anemia of pregnancy, which is because of improportionate increase in plasma volume and RBC volume. So there is less decrease of RBC volume as compared to plasma volume. Cardiac output increases by 40 to 50%, stroke volume increases by 25 to 30%, heart rate increases by 15% to 25%. So as we all know, heart rate into stroke volume is cardiac output. So what we can remember is 20, 30, 40. 20% increase in heart rate, 30% increase in stroke volume, 40% increase in cardiac output, just to remember. Then the femoral venous pressures increase by 15%. What parameters decrease? SVR decreases, leading to decreased BP. Pulmonary vascular resistance decreases. There is no change in central venous pressure and pulmonary capillary wedge pressures. After these parameters are taken from standard book Miller's. After discussing parameters, we will discuss the individual changes in cardiovascular system. So, due to more increase of plasma volume and less increase of erythrocyte volume, there is dilution of the blood, leading to dilutional anemia or physiological anemia of pregnancy. What are the advantages? It's a God's way of saving blood. What happens is viscosity decreases. There is decrease in hematocrit, leads to improved placental circulation, better placental circulation, better fetal circulation, then compensates for the blood loss. As the blood is diluted, there is dilutional anemia. So the hemoglobin loss will be less and it compensates for the blood loss. The systemic vascular resistance decreases, blood pressure decreases, there is less response to vasoconstrictors and adrenergic agents. The response to adrenergic agents and vasoconstrictors is blunted in pregnancy. Decrease in HB is compensated by increase in cardiac output. If we talk about average blood loss, if we talk about normal vaginal delivery, there it is approximately 400 to 500 ml, and if it is a twin pregnancy, it is around 1000 ml. If we talk about cesarean section, the blood loss is around 1000 ml. So the total blood volume increases to 90 ml per kg and it returns to normal in 1 to 2 weeks after delivery. Cardiac output, as we have discussed, maximum rise immediately after labor, returns to normal after 12 weeks to 24 weeks, and decreases in supine position. One of the important topics we have to know in pregnancy is supine hypotension syndrome or aortocaval compression. It occurs in 5% to 15% of women. Signs and symptoms that we can see in a woman are pallor, sweating, nausea, vomiting. They can be associated with bradycardia and hypotension. So what happens is it is due to complete or near complete or matlab complete or partial obstruction of the inferior vena cava. It can occur, surprisingly, it can occur as early as 13 to 16 weeks of period of gestation. And what happens is it is compensated by collaterals. So this point we have discussed earlier also, that distended uterus leads to complete or near complete obstruction of IVC, leading to increased epidural venous plexus volume. In the in increase in epidural venous plexus volume also happens because of collaterals, and how to avoid this is we will turn the patient to her left side. Turning the patient on her left side will release the pressure from the IVC, which is on the right side of the patient. So we have to always place a wedge more than 15 degrees up to 30 degrees under the right hip, so that the IVC on the right side of the patient does not get compressed by the distended uterus. So positioning a pregnant patient is an anesthesia concern, and it will then not compromise the IVC and the collateral veins. So if by chance distended uterus compresses aorta, aorta compression will lead to decreased blood flow to the level below the compression, that is lower extremities, and will compromise the uteroplacental circulation. So other things we can see in chronic, if the patient is chronically, there is partial IVC compression, we can see stasis, venous stasis, phlebitis, and edema. So whenever a pregnant patient is lying supine, we have to use a wedge and turn under the right hip and turn the patient on her left side, so that there is no compression or there is no partial compression on IVC. Supine hypotension syndrome along with anesthesia. Supine hypotension syndrome along with anesthesia, GA or regional, may lead to fetal asphyxia. So anesthetist, you have to keep this thing in mind, that if there is a pregnant female, she should be shifted to her left side, left lateral position, so that there is no compromise on fetal circulation or uteroplacental circulation. One more point I would like to add here is, suppose you are presenting a case of a pregnant woman and you have to and you are at that point where you are shifting the patient inside the OT. If you say that the patient will be shifted inside the OT in left lateral position, you will get bonus points. If you start your case like this, examiner will be really impressed. So we have to keep it in mind that while shifting a patient for OT, we can write this on our PAC sheets as well, that while shifting the patient for OT, please shift the patient on her left side or left lateral position with a wedge under her right hip. Talking about changes in heart, there is left axis deviation is seen, myocardial hypertrophy is seen, exaggerated splitting of mitral and tricuspid components are also seen. The heart shifts upwards, outwards, and towards the left side. Upwards, outwards, and towards the left side. One more star point that we have to remember is diastolic murmur in a pregnant female is not acceptable. Systolic ejection murmur is physiological change in pregnancy and can be present in pregnancy. Grade 2 systolic murmur is acceptable in pregnancy. But if the murmur is diastolic, we have to be alert and evaluate the patient further to find out the cause of diastolic murmur. If we talk about changes in ECG, heart rate dependent decrease in PR and QT interval will be seen. The QRS axis shifts to right in first trimester and left in third trimester. There can be seen ST depression in left precordial and limb leads with approximately 1 mm. If we talk about 2D echo of a pregnant female, heart shifts anteriorly and left. There is left ventricle eccentric hypertrophy. Ejection fraction increases slightly. Mitral, tricuspid, and pulmonary valve annuli increases. Tricuspid regurgitation and pulmonary regurgitation are common. Mitral regurgitation occurring 27% of the pregnant women. If we talk about pericardial effusion, 40% of the pregnant women at term at around third trimester may have pericardial effusion. So this was about cardiac system. We have to keep in mind that the patient is in left lateral position. The only anesthesia concern related to cardiac is the patient should be placed in left lateral position, and we have to rule out diastolic murmur. Diastolic murmur should not be present in a pregnant female. Talking about renal system, there is increase in renal blood flow, there is increase in glomerular filtration rate. The blood urea nitrogen decreases to 8 to 9 milligram per deciliter. Normal is 10 to 20 milligram per deciliter. Serum creatinine decreases. It comes to 0.5 to 0.6 milligram per deciliter, while the normal limit is 0.6 to 1.1 milligram per deciliter. So if a pregnant female has a creat of 1, it is high for her. We should not ignore this. Then patient may have mild glycosuria, patient may have proteinuria, which can increase as gestation increases. Plasma osmolality is low by 8 to 9 milliosmoles per kg. If we talk about gastrointestinal system, we all know that pregnant females have gastroesophageal reflux, which increases with gestational age. It is also associated with multiparity, and if there is previous history of gastroesophageal reflux. However, if the maternal age is more, the chances of gastroesophageal reflux are low. So the relation of gastroesophageal reflux with maternal age is inverse. If other changes in gastrointestinal system are, patient may have esophagitis, decreased gastric motility, and upward and anterior displacement of stomach, which is due to distended uterus. So this leads to incompetence of gastroesophageal sphincter and can increase the risk of regurgitation, which increases the chances of pulmonary aspiration. So in GI system, what we have to keep in mind that the patients are at risk of aspiration. The angle of gastroesophageal junction, angle of his, becomes acute. The angle becomes acute, the tone decreases, and it further decreases due to opioids and anticholinergics. There is delayed gastric emptying due to delayed gastric mobility. There is decreased intestinal peristalsis. So, fasting guidelines should be strictly followed, and if the patient is not uh, nil per hour adequately, then we have to take the risk of aspiration. So, what till what period of pregnancy there is risk of aspiration? It is from 6 weeks of period of gestation up to 48 hours postpartum. So, if we take a patient post delivery for retained products of retained products of placenta or any tear, a vaginal tear, then we have to consider that the patient may have risk of aspiration. So we are aware of a term known as Mendelssohn syndrome. It has specific requirements that the pH of the aspirate is less than 2.5 and the gastric volume is more than 25 ml. These two parameters may lead to aspiration pneumonitis. How can we prevent this? To prevent this, we will use H2 blocker, Rantac. What it does is it increases the pH. It does not have any effect on gastric volume. It just increases the pH so that in case aspiration occurs, there is less damage to the lungs. If we talk about other treatment drug, metoclopramide, which is D2 as well as 5-HT3 inhibitor, it increases the lower esophageal sphincter tone and it fastens gastric emptying. So the volume, gastric volume is changed by this drug. Another drug which is used is sodium citrate, which is, we have to remember, 333, 0.3 molar in concentration, 30 ml in volume, and it should be given 30 minutes before procedure. So 0.3 molar, 330 ml and 30 minutes before procedure. After Mendelssohn syndrome, so in gastric system, we have to remember that the patient is at risk of aspiration from 6 weeks of period of gestation up to 48 hours postpartum. And we have to provide, to avoid Mendelssohn syndrome, we have to increase the pH of the gastric content and we have to increase gastric emptying. Talking about hepatic system, there is increase in hepatic blood flow. There was increase in renal blood flow. There was increase in renal blood flow, but the hepatic blood flow does not changes. The hepatic functions does not change. There is minor increase in serum transaminases and mild increase in serum ALP, which is secreted due to, which the increase is due to secretion by placenta. So there is no change in hepatic blood flow in contrast to renal, where there is increase in renal blood flow. So there is mild decrease in serum albumin. There is decreased plasma oncotic pressure. If we talk about pseudocholinesterase activity, it decreases by 25% to 30% and becomes normal in 6 weeks after delivery. So if we are using succinylcholine, the duration is not affected, but the pseudocholinesterase activity decreases by 25% to 30%. Due to progesterone, there is inhibition of release of cholecystokinin leading to incomplete emptying of gallbladder. Incomplete emptying of gallbladder makes patient prone to cholelithiasis or gallstones. So patient become vulnerable or prone to gallstones. If we talk about hematological changes, so pregnancy overall is a hypercoagulable state. Why it is a hypercoagulable state? Because so that if there is more blood loss, it is compensated during labor by its hypercoagulability. So what all factors increase and what all factors decrease in coagulation system during pregnancy? So there is increase in factor 1, 7, 8, 9, 10, 12 and 1 Willebrand factor. So factor 1 fibrinogen increases, stable factor 7 increases, antihemophilic factor 8 increases, Christmas factor 9 increases, Stewart-Provar factor 10 increases, Hagman factor 12 increases and von Willebrand factor increases. Factors which decrease are 9, 13, antithrombin 3, and tissue plasminogen activator. So we have to remember factor 9, plasma thromboplastin antecedent decreases, fibrin stabilizing factor decreases, antithrombin 3 decreases, and tissue plasminogen activator decreases. There is no change in factors 2 and 5. Prothrombin, there is no change. Labile factor, there is no change. So if we talk about TLC, total leukocyte count, there is increase up to 15,000 per microliter. And while giving regional anesthesia, we have to see that there is normally increase in TLC and we can give regional anesthesia because there is normally leukocytosis seen in pregnancy. However, if there are clinical signs of sepsis, there are clinical signs of uh, infection and the TLC is more than 15,000, like 20,000 or 22,000, then we have to reconsider our decision about giving regional anesthesia to the patient. Talking about platelet count, there is decrease in platelet count 0% to 10%, and we have to get it investigated in HELLP syndrome, suspected HELLP syndrome patients, and in patients in whom we suspect PIH. So if the platelet count is more than 75,000 per microliter, we can plan or we can go for regional anesthesia, but we have to keep in mind that the spinal is given by an experienced anesthetist and it should be single shot spinal. If we talk about a range which is borderline like 50,000 to 75,000 per microliter, then we have to see if there are clinical signs of bleeding. What is the trend of platelets? Trend of platelets is very important and we have to see the INR. And we have to reconsider based on these things, we have to reconsider our decision that we will go for regional or GA for this patient. Talking about other factors, there is decrease in prothrombin time and partial thromboplastin time. The text shows hypercoagulable chart. The FDP increases, plasminogen increases. If we talk about iron and folic acid, patient is susceptible to iron and folic acid deficiency if not supplemented. After this, we will talk about metabolic changes. So, if as we were discussing hematology, then we said that the patient is in hypercoagulable state. So if we talk about metabolic, the patient is in starvation state. Blood glucose decreases, amino acids decrease. There is increase in fatty acid, ketones and triglycerides. Patient is in diabetogenic state due to increased, which leads to increased insulin. The human placental lactogen, also known as human chorionic somatomamotropin, it is secreted by placenta, provides relative insulin resistance. And there is pancreatic beta cell hyperplasia. There is increase in HCG. and increased estrogen. Increased HCG and increased estrogen leads to hypertrophy of thyroid gland and can increase the thyroid binding globulin, and free levels of T4 and T3 might increase. If we talk about calcium levels, serum calcium levels decrease, but the ionized calcium levels are normal. Due to increased estrogen and progesterone, there is increased plasma renin, and via renin angiotensin aldosterone system, there is increased sodium absorption and water retention. As we see that the pregnant females might have edema, pedal edema is due to water retention. Progesterone also increases aldosterone and causes the same increased sodium absorption and water retention. If we talk about musculoskeletal system, there is increased release of relaxin, which makes the cervix soft, ready for delivery. It inhibits uterine contractions and it relaxes the joints. Pubic symphysis is relaxed and pelvic joint is more uh, open to deliver the baby. The ligaments become lax due to hormonal changes and can lead to back injury or back pain. Exaggerated lumbar lordosis due to distended uterus may cause back pain. So, all of you must have um, heard from the patient that do not give spinal because it causes backache, and we have heard it from our relatives and we have experienced it earlier. So we have to explain this to the patient that spinal is not the cause of backache. Lumbar lordosis, exaggerated lumbar lordosis and ligamentous laxity is the cause of back pain, mainly due to pregnancy, and you have to work on strengthening of back muscles to avoid back pain. So, just an addition about body weight and composition, there is maternal weight increases by 17% of pre-pregnancy weight. So approximate weight gain is 12 kgs. First trimester approximately 1 to 2 kgs, and in second and third trimester it is approximately 5 to 6 kgs in each trimester. So the weight is distributed as shown in the table. Uterus approximately 1 kg, amniotic fluid approximately 1 kg, fetus and placenta approximately 4 kgs, blood volume and interstitial fluid approximately 2 kgs, new fat and protein deposition approximately 4 kgs. Another term that I would like to discuss in this class is autotransfusion. What happens is we have learned that the blood get hemodiluted, it is more diluted, and during labor the uterine contractions displace the volume from the placenta, from the intervillous space of placenta through ovarian venous outflow system into the maternal circulation. So it is like the placenta gives blood to the mother, and so that this is known as autotransfusion, so that mother does not have much blood loss. So what we can predict from this is, what we can estimate from this is that blood loss during normal vaginal delivery or cesarean need not be replaced if it is within normal range and not considered in estimated blood loss. So autotransfusion is also a nature's way to protect mother from more blood loss, similar such as hemodilution, so that around approximately 300 ml to 500 ml is transfused back to maternal circulation and she is compensated for the blood loss. So, this was all about each system. Now, if we talk about physiological changes in pregnancy affecting anesthesia. So, if a patient comes and we have to do pre-anesthesia checkup, we have to keep in mind that the patient is at risk of aspiration, and we have to consider airway assessment. We have to consider that patient might have edema, patient might have increased capillary engorgement, the MMPG grade might be higher. So, after PAC, for example, if we are planning a general anesthesia for the patient, so if you say this line first, in your case, you will get bonus points. Shifting the patient in OT in left lateral position will gain you marks, extra marks in your exam. Examiner will be impressed. So, um, we have to keep in mind that the patient is shifted in left lateral position in the OT. On OT table, we will use wedge. We have discussed why left lateral, why using wedge. Then slightly propped up, I have written just to increase the FRC if allowable. Then if we are giving GA, we have to pre-oxygenate the patient. Why? Because the oxygen consumption is increased in pregnancy and the FRC is decreased. It will lead to faster desaturation of the patient. So in order to buy time for securing the airway, we have to pre-oxygenate the patient well. As the minute ventilation is increased, the endpoints of pre-oxygenation are achieved early. We have to avoid opioids as it causes respiratory depression in the baby. If we talk about induction agents, the dose of induction agents decreases, and we have already discussed the volatile agent MAC decreases, uptake is faster due to increased minute ventilation. If we talk about relaxant, muscle relaxant, if we give succinylcholine, the duration of block is not changed in spite of pseudocholinesterase activity decreased in pregnancy. And we have to also keep in mind that the sensitivity for neuromuscular blockers is increased in pregnancy. Chronotropic agents and vasopressors have blunted effect or decreased sensitivity. So during hypotension, we have to manage it very well. Talking about intubation or securing an airway, experienced anesthetist should be present. The laryngoscopy should be gentle, swift by an experienced anesthetist, and we have to prefer a smaller size endotracheal tube. What we have to remember is if we are giving general anesthesia to the patient, as soon as we confirm that the tube is in place, surgical incision should be given. So, in order to decrease the passage of drugs to the fetus, we have to ask the surgeons to be ready while we are giving GA. The patient should be clean, draped, painted, with surgeons washed, with scalpel in their hand, ready. As soon as we confirm that the tube is in, they should give the incision in order to save time and protect baby from the passage of drugs into the uteroplacental circulation. So if we are planning neuraxial block for a pregnant female, positioning is important for neuraxial block. Usually sitting is preferred, and if we give lateral in case the patient is not able to sit, we have to keep in mind that the pelvis of a female is wider than the shoulders, so the tilt is head down tilt. So we have to go in a direction of the spinal needle should be in such a direction that we consider the head down tilt of the patient while in lateral position. The spaces, intervertebral spaces are decreased. There may be edema in the back due to water retention. So difficult identification of intervertebral space can be there. We have already discussed that the local anesthetic sensitivity increases. So we have to decrease the dose, and there might be increased capillary spread of the drug due to distended uterus. Then epidural placement might be intravascular, and we have multiple confounding factors to avoid test dose. We have to avoid adrenaline, and we have to avoid giving test dose while patient is having contractions. There is decreased response to vasopressors. So I'll just a brief of if hypotension happens after neuraxial block, what we can do. So there is a concept of preloading and co-loading. So crystalloids are first line. We have to give crystalloids. If the patient has supine hypotension syndrome, or in supine position patient is getting low BP, hypotension and tachycardia, if the heart rate is more than 90 beats per minute, then we have to prefer colloids, but we have to rule out the coagulation abnormalities, renal dysfunction. So, avoiding all the contraindications for colloids, we can use crystalloid as well as colloids, and we can give it during co-loading while preparing for spinal anesthesia, and we can preload also as well, depending on the institute to institute practice. If the patient has hypotension, there are two drugs which can be given, phenylephrine and ephedrine. So phenylephrine decreases the heart rate and is an alpha 1 agonist. It is given in a dose of 25 micrograms to 50 micrograms or 100 micrograms depending upon the response of the patient. Ephedrine is alpha plus beta agonist. The heart rate increases and ephedrine passes through the placenta. So first line is phenylephrine followed by ephedrine. So it decreases the fetal pH. So we have to prefer phenylephrine over ephedrine. And mechanical factors which can improve the hypotension are leg lift and pneumatic compression use. So this was all about the physiological changes in pregnancy, along with the anesthesia concern in each system. And finally, if we are giving general anesthesia, what are the anesthesia concerns? And if we are giving neuraxial block, what are the anesthesia concerns? If you like this video, please give it a like, please subscribe and share to as many of your colleagues as you can. And if you have any suggestion, please write it down. Thank you so much.